Hello everyone, and welcome to today's episode of the Global Training Committee webinar. I will be speaking on the management of keloids and its current trends. Our speakers for today will be Dr. Jean C. Kagimbana and Dr. Emmanuel Uwizeyimana. You're welcome. I'll be your host for today. My name is Linda Adson, and together I'll be co-hosting with Josh from the US. Who are the Global Training Committee? We are a part of the International Alliance for Global Health Dermatology under the International Foundation for Dermatology. Our mission is to promote knowledge equity by enhancing access to dermatology education worldwide. Our key initiatives include educational webinars where we give high and free quality learning opportunities. We also give room for networking and collaboration by connecting trainees worldwide. We also have a podcast series that addresses challenges in global health dermatology, and you will find these podcasts on our websites, and we also have the snippets on our Instagram channel. So for the duration of this meeting, your audio will be muted and your cameras will all be turned off. If you have any questions, you can submit via the chat function or the Q&A box. The meeting host will share these questions to the speakers at the end of the webinar. And we'll also be sharing further information about the Global Training Committee in the chat function. So I'll be introducing our speakers. We have Dr. Jean C. Kagimbana, who is a Chief Consultant Dermatovenerologist and Associate Professor at the Dermatovenerology Department in the College of Medicine and Health Sciences at the University of Rwanda. Together with him is his resident, a trainee of dermatovenerology, also of the same institution. So without further ado, I'm giving room to Dr. Kagimbana and Dr. Emmanuel to take their lecture. Thank you.
Okay, hello everyone, good morning, good afternoon, and good evening to everyone. Yes, I'm by the names of Dr. Emmanuel Uwizeyimana. I'm in year one resident in dermatovenerology in University of Rwanda. So today I'm happy to be here on this platform, Glodelm. It's my first time to present, it's amazing. And also the way I'm going to present on the management of keloids and the current trends, it's also a good thing because when I was in medical school, I did my thesis on the prevalence, associated risk factors, outcomes of aerobic keloids. It was interesting, it was so motivating to see the patient presenting those conditions, which was my first time. So let me start. This is my outlines. I will just pass through the case scenario, introduction, background, epidemiology, and then pathogenesis, risk factors, clinical features, and then Dr. Kagimbana will pass through in details about the treatment of the keloids and also the current trends. So we declared no conflict of interest, and also let's start on the case. So here we received 2 years ago, we received one case of 27-year-old female patient who came from the rural area complaining about the gradually enlarging the farm and tender mass on both areas for almost 3 years. So she was presenting the bilateral aerobic keloid, which was the interesting the case, and also the patient was having like the problem to just in the society because of those conditions. Some in the society they perceived as like a poisoned, and also for him she was distressed because of this condition. So we received the patient, and also we scheduled the patient next day for the surgical removal for this condition because we examined her and we found that it was a massive keloids on the earlobe. So these are on day one when we did the surgical excision. On the first image, you can see the left ear when we completely excised the keloid, And also in the picture 2, it was when completely removed. And also you can see on the following images when this condition was removed. And also this is the 8th post-surgery when the patient came to the clinic just to remove some distressing and then check what was in. And also we found that big keloid, we excised completely so that you can see the patient is doing good. You can see on the earlobe, it's okay. The patient is happy because we tried to remove those keloid. It was bilateral. So now this time the patient is happy. She can also interact in the society because she's already feel the comfortable for her condition. So let's pass through about the introduction. So the keloids and hypertrophic scars have some tumor-like properties. And also they are actually a inflammatory condition that drive the overproliferation of dermal fibrosis. And also it's a aberrant of dermal matrix, which caused by when there is healing of injured and also irritating the skin. So we have seen that the keloid is caused by different conditions. It can be injury, which can lead to the irritation. It can be caused by intradermal vaccination, which it can irritate the reticular part of the dermis. And also it can be caused by skin piercing, especially to the ladies. And also it can be caused by acne and then herpes zoster. So the likelihood of keloids and also hypertrophic scar, it's almost went significantly elevated when the wound penetrates deeply into the reticular layer of the dermis. So this risk is further compounded by the genetic factors, systemic, and also even local factors that can extend the inflammatory phase of the wound. For the keloids to happen, there should be this extent of the inflammatory phase which happen to affect the reticular area of the dermis. And also, it's a prolonged inflammation which can enhance the angiogenesis and also induce the overproduction of collagen. So about the historical background of the keloids. So where was this condition started? So the keloids were first described in the smooth papyrus around 1700 before Jesus Christ. It was found in the medical text of the Egypt and also the Yorubas of Western Nigeria depicted the keloids in the scripture in that mentioned century. And it was first clearly described by this dermatologist, the French dermatologist called the Albert, and also this term was also derived from Greek word which called the kere, meaning club like claw. When you try to observe how the keloid looks like, it's like the club claw. And also in 1825, the Albert entitled this chapter on this region called the cankeroids or keloids. So going to the epidemiology, the global keloid occur around 5 to 15% of the wounds, and they affect both sex equally, but they found it more predominant in the females because of the cosmetics purpose. You found those ladies, they are trying to put some ear piercing. That's why the females predominate about having this keloid. And also the frequency of keloid occurrence are found commonly in highly pigmented skin at the rate 15 times higher than in person which is less pigmented. You can see that this difference is big enough for those people who are highly pigmented. So they did some hospital-based studies in Africa where they reported the keloid general to be 9% and 8.5% among pigmented skin from Zambia and also Kenya, respectively. So average estimation of keloids worldwide, like you can find in Africa, it's around 5 to 10%. And also in Asia, it's estimated to be 0 to 0.1% in Asia, and also less than 0.1% in a continent. You can see clearly there is a huge difference in Africa and the other continents. We are going to see what's the reason behind of this big difference. So you can see the geographical distribution, like the regions with high UV exposures, like those countries live near the equator, like the South Sudan and Kenya. You find those people, they are highly to have a keloid compared to other parts of the country. So to date, there are no high quality data on the prevalence and also incidence of keloids in Rwanda, but we are trying to see how I can publish my research on the keloids. That will be so interesting to see some data from Rwanda. So let's see what's the reason behind how the keloids is formed. Mainly, the keloids, the poorly understood the mechanism how the keloids formed. So there's some hypotheses say that when there is wound healing in mass and blood clots forms as the first step in the reticular layer of the dermis, there will be imbalance between degradation and also biosynthesis of the collagen and also fibroblast, which will lead the persistent fibrosis.
And also
there will be recruitment of the transforming growth factors, where we have this transforming growth factor B1 and also transforming growth B2, which found to promote excess collagen production to the keloid formation. So this growth factor beta 1 and beta 2, they are almost found in those patients who have the keloids. This TGFB1 and TGB2 are more compared to other peoples without having the keloids. And also we found the role of immune system. They found that Th2 response stimulates the fibrogenesis and leading to the excessive collagen production and also fibroblast to the area of the injury. And they found the Th1 response, it has lesser effects on the keloid formation. And also they found this, the genetic predisposition also contribute a lot, and you can find these other factors, but when this genetic predisposition is paramount than others. So going to the risk factors, we have the different risk factors which can cause the keloids. We have local tissue factors, we have other local factors, and also we have the patient-related factors. On the local tissue factors, we have like mechanical stretching forces. We have those areas which are like anterior chest and also upper back. So this area, if they happen to have an injury, there is due to these stretching forces, it keeps having the inflammation in that area because of these stretching forces. And also we have the area which has less likely tensions like the parietal regions, anterior lower leg, and also the upper eyelid. This area is less likely to have the keloids. And also we have other local factors like cutaneous infection, those patients who have different infection. You can see the people with the acne, and also those people with infected ear lobe, piercing, and also intradermal administration of the vaccines. So this condition keeps having the inflammation on the scar, which leads to overproduction of the collagen and also fibroblast at the site of the injury. And also we have the patient-related factors like these genetics. So on the genetics studies, they found multiple pedigrees with family keloids in autosomal dominance. So like in our hospital where we have the keloid clinic, we used to see some patients with the keloids, and when you try to ask in the history, and also they say that there is other family members like her father, her mom also have the keloids in the family. because of the genetics. And also we have the other factors like the age. For the age, you see those younger patients, they try to do some piercing. You found those people have the keloid, and also some hormonal conditions like the estrogen and also progesterone. They found cause this overproduction of the fibroblast and also collagen in this condition. And also sex hormones, I said about the surge of this estrogen and also progesterone, they contribute a lot for the inflammation process and also this fibroblast production. And also the hypertension, if a patient happen to have like the hypertension, we know the hypertension can cause the damage to the endothelial vessels, which leads the permeability of the vessel, leads the inflammation, and also it contributes to the fibroblast production. And also the pregnancy, mainly used to see the case like those patients who undergo, those female who undergo the cesarean section, you find they have keloids on the cesarean scar. So it's because of this surge of the progesterone and also estrogen, and also we found those pregnant mother who take some different vaccination before they have this keloid. So let's talk simply about the special sites consideration. I have said before the irid and also yellow keloids. For the irid, to have the keloids, as I say, it's very rare. So because our eyes are always open and closed, so it's always relaxed. So that's why in the irid, it's rare to see the keloids on the irid. So the special on the ear keloid, as I have said in our setting where we have the keloid clinic, we have many patients who have the ear keloid, but the reason behind it is because of this attachment and also detachment of piercing, which leads the injury, infection, and also initiate the proliferative process and also some skin tension because of this piercing. So I also pass through, in summary, my research I defended 2 years ago to see how this patient keloids, we have many cases there at our clinic. So in summary, skin tension may not be the main cause of keloids and also hypertrophic scars. There is significant local risk factor that worsen when there is this prolonged inflammation is the one responsible for development and also progression of this collagen to form the scar. So about the clinical features of the keloids, we have the symptom. You find the patient presenting pruritus, the swelling, and also cosmetic disfigurement. This condition is somehow worrisome because where the place takes, and also some burning sensation on the area. On the signs, when you try to do the physical exam, it's more elevated erythematous lesion with the glossy surface on the palpation. On the white population, it looks like red color, but the black population, it's like a violaceous black when you see the keloid. So let's back us through my thesis. It's like research done on yellow keloids, done at Rwanda Military Referral and Teaching Hospital. Let's see in summary our findings and also the insights. So keloids are the most common dermatological condition found in our clinic. So among 198 patients who consulted keloid clinic at Rwanda Military Referral and Teaching Hospital around 2018 and 2021, we found almost 100 patients, which is equal to 50.5% with EROB keloids. So the reason why I highlighted this is because it's our main concern in our research we did. And also the 58 patients, 29.3% with chest keloids. So other 15 parts, we have 40 patients. So these are the patients with the full identity and also their address. So that's why you can say somehow still have the raw numbers. So the general picture, The most observed finding risk factors of aerobe keloids, it's the most commonly caused piercing at the rate of 74.0%. Other minor, like the acne, those burns, we have around 26.0%. The sex predilection is a female, 84.0%, which are more common because of this piercing. The male was around 16.0%. The dominant age group affected was around 21 and 25 by 43%. So these are the different treatment approaches we used on this patient. We found that those who used, and also we know that this treatment approach depends on the size of the keloids and also on the site. From the new guideline, they say that if the surface area is less than 20 square centimeters, taken as low to moderate, it's above 20 centimeters square root, taken as the large keloids. So these are the different treatment approach mainly used in intralesional injection and also surgical treatment. We found the patient who used around 55.0%. Intralesional injection and cryotherapy is around 10.0%. And those who use the surgical treatment, and we know that this surgical treatment leads more recurrence, it's 9.0%. Because this patient, they didn't just came for the follow-up. So we found it's around 9.0%. And those who use the injection treatment only, it's 5.0%. And those who use the injection cryotherapy plus surgical excision, it's around 0%, 3%, sorry. And these are the success rate. We tried to communicate with those patients. They just tried to tell us that for me, there was no recurrence. It was good. For those who use intralesional injection at triamcinolone stone and excision, the success rate was around 70%. And those who use the injection plus cryotherapy, it was around 12.8% success rate. And also those who use the surgical excision alone is around 11.4%. This we know that the surgical excision, it is the more recurrence, and we tried to just to see this patient under 1 year when he was already completed the treatment. And also intralesional injection plus cryotherapy, the success rate was around 28%. And those who use intra-injection only, the success rate was 28%, which was still low in that time. And also about the recurrence rate after successful treatment, like around 68% of the patient who they reported no signs of recurrence, plus those who used the surgical alone, which was amazing to see these big numbers of the success rate. And also the recurrence reported to be around 70%. And also those who were still under follow-up, there was 16%, and 90% of the patient failed to meet this scheduled follow-up. So these are the reference, and thank you for the kind attention. We look forward for the insightful discussions. Thank you so much. Maybe we can welcome my supervisor, Dr. Kagimbana, to proceed on the details of the management of the keloid and also the current trends. So, thank you.
Good morning, good afternoon, or good evening from where you are. I am Dr. Kagimbana. That's closing. I'm Dr. Kagimbana. I am the chief consultant dermatologist. I'm working at Rwanda Military and Referral Teaching Hospital, and I am the chair of the dermatology department from the Rwanda University College of Medicine. Thank you for your attention to this presentation. I just share you the introduction, the subject, which will be one to start my presentation. Then I will proceed to different most commonly used keloid or hypertrophic scars treatment. And then I end with our experience in the dermatology, where we have a clinic of keloids, because we have so many keloids that who are attending our clinic. Now, I think Dr. Emmanuel has shared why keloids and hypertrophic scar, which have some tumor-like properties, and the main cause is the inflammation, which is maintain the process of keloids or hypertrophic conditions that drive to the excessive proliferation of fibroblasts. And then there is an aberrant accumulation in the dermal matrix caused by abnormal healing or injured or irritated skin. And especially in those people who are predisposed, even a small scratching or acne is followed by a keloid formations, like we have even in vaccinations. And most of our patients just come to us with ear post keloid post piercing of ear. The likelihood of keloid hypertrophic scars forming is significantly elevated when the wound penetrates deeply enough to damage the reticular layer of the dermis. Emmanuel have also mentioned it. And it is associated with subjective symptoms, pain, itching, and of course, sensation of contraction. And the primary treatment endpoint for keloid or hypertrophic scars should focus on functional improvement, that meaning that we have to remove the keloid or hypertrophic scar, relief from the pain and itching, of course, the aesthetic improvement. These are the three components which we keep attention to them. Then, several approaches are here mentioned, and in our conditions, some of them are not used because, like surgery, yes, corticosteroid therapy associated with surgery or alone, compression therapy, stabilization therapy, cryotherapy. These are the treatment we are just using alone or combining. And radiotherapy, we have not the machine for this. Then we can use other treatment like chemotherapeutics, like bleomycin or FEU. Then the surgical treatment alone, it is self-induced the inflammation. And we know that is the inflammation which maintain the keloid formation. Then this inflammation is associated with high recurrence rate of keloid, and some authors say that even when we treat keloids without a combination of other treatment, the rate treatment goes up from 50 to 100%. Then the recurrent scars are often larger than the original lesions, meaning that when we use the surgery, the maintenance with adjunct therapy like this calcineurin intralesional injection, then is combined immediately or later in a follow-up, meaning that even the decisions of surgery is done, we have to consider additional treatment. Now, the primary objective of keloid treatment is that we have to remove the tumor, which is most of the time, which is exuberant tumor, which we have to remove. But for some regions, we have a flat or flattened keloids where the surgery will not be possible, then we have to use other therapy. Knowing that when we use the surgery, we favor the local flaps or Z-plasty, or which have advantage just to reduce the tension within the wound, because the tension itself maintain the recurrence. Then we have to use the local and Z-plasty, and when we have to suture, we have always to use the small size of like 5 or 6 or sutures. And skin grafts are not recommendable, although in some patients like aerobic treatment, we may just use it. Meaning that for huge keloids, just which are protuberant, we have to reduce surgically, and then additionally, we have to combine with other keloids, other treatment. Now, for this flat or big keloids, we have to go for other treatments. Now, practically, in surgery, we have to use local or Z-plasty surgery to reduce tension, and most of the time, around 80%, we add triamcinolone acetonide intraregional injection. Now, corticosteroid therapy, the one which is the most used is triamcinolone. And this one is used and is considered as a gold standard in non-surgical management of keloid, although it's associated most of the time in our setting surgical treatment. Of course, now that these intraregional injections have some side effects during the injections, because it's associated with the pain, and later on with the skin atrophy and hypopigmentations. These are the most side effects we have to know, and the technique has to be well done. For example, we have to use the small gauge needles, those one with high gauge numbers are used for intradermal injection. In our setting, we use these insulin needles, and then consider pain, because this injection is very, very painful. And initially, we may consider this local anesthesia, these applications like cream, EMRA, just prior to the local injection of triamcinolone injection. Now, of course, we have to keep in our mind as the first or the second injection when we have a patient who may experience some anaphylactic shock, which is possible, and meaning that we have always to be close to the adrenaline. And when the patient some report like chest discomfort or respiratory problem, immediately you go to adrenaline injection to stop this process toward the anaphylactic shock, because we had some patients in the past with these side effects. Now, of course, we consider side effects like skin depigmentation or if subcutaneous injections. Usually, a good technique with experienced doctor have to avoid all this, and I think should be a routine of knowing how to use intraregional injection with triamcinolone acetonide. Now, the second type of corticosteroid therapy is steroid tape or plaster. We have many brands. These are the tape or plasters which usually are associated. These are used for patients who are subject to have keloids. You know that in pigmented skin, like type 4, 5, these people are subject to have keloids. Now, after excision, for example, scissor section, always I consider the use of these steroid tapes or plaster. Now, in other conditions, it's not mentioned here, we may use after surgery, especially when you have the option was a shaving, immediate post-surgery, after dressing, we may use the high potent steroid like clobetasol propionate, which can be used on daily basis until the wound is healed. This has been shown very efficient to stop the progress of keloids. Now, these are used mainly as a preventive measures on large wounds with a daily wound dressing, and they have been useful in post-burn wounds, where we have to prevent with tapes or plaster applications. Now, stabilization therapy, we have said that the wound when in its healing process, you have stretchings which can evoke the inflammation of the reticular dermis. Here, it's where we have to consider this stabilization therapy, which can help us to moisten the scar and to stop the progress of this process of keloid formation. Now, of course, we always, in additional treatment, we always add other treatment like intralesional injections, because we have no own therapy which can prove its efficiency. The wound stabilization, just stretching wound can evoke, I have said this is a repetition. And I think we, in our settings, we have like this Sikakea silicone gel, which are usually added to these large wounds in additional therapy, just to stop the progress of the keloids. Now, large keloids, in addition to other therapy, like, for example, triamcinolone acetonide injection. Now, declarar therapy, now it's another component of treatment of hypertrophic scars or keloids. And most of the time, it's combined with intralesional triamcinolone. And it has been proven that combined with TR or triamcinolone acetonide intralesional, the efficiency increase comparing when you are using it alone. Now, this therapy, we have first, when we opt to use it, we apply liquid nitrogen to freeze the keloid before injecting the medication. And this softens the keloid and makes it more amenable to treatment and easing and make it useful when combined to intralesional treatment. And we have to repeat this every 3 to 4 weeks. Mainly, folks have been shown to be necessary just up to 3 or 4 sessions. Small keloid or on the area of keloid with active regions may be done within a large keloid. That this active where the patient report itching, then this can just can be targeted for chemotherapy, while other areas are just considered for triamcinolone acetonide injections. Now, in our setting, we don't have this radiation therapy. I have been using it when I was in my residence in Moshi. I think people who are following us, I think they know it. And this was used especially even for these large keloids, even for the aerobic keloids, because they have a strong anti-inflammatory effects. Then primary therapy radiation is suitable for all the patients with severe or large keloids, because it has also some side effects, and we have to consider all these parameters before we go, we take option for this treatment. And the treatment is done immediately after the surgical procedure. Then meaning that all surgery may be completed by radiotherapy. Now, I think this is also we have said this. Of course, we have to know the side effects of radiotherapy, which may be taken into account, and when combined with the surgery, I think the efficiency, its efficiency is very high. Now, like chemotherapeutics, in the literature, we have seen that bleomycin and fluorouracil 5% is used. And in my own experience, I have used bleomycin, which may be also considered and currently the one now done. I don't have the most knowledge with intraregional injections, but or the needle-free jet injection, which are the most which can be used now. But the one I know is puncture. Using, we have some moderation of it with a normal saline, for example. Then with the small needle, like 18 gauge, that we puncture the area of the keloids. Of course, the recurrences are high. We can also combine it with other therapy like intraregional injections. Now, there is a therapy. Yes, we have now for people who may use it. Yes, in our setting we don't have. But compression therapy, we have mentioned it because in some area like where a compression may be done, like for example on feet, we can advise patients to just, in addition to the treatment mentioned above, just to wear these compressive stockings, which are large, then they put these tightened shoes. And this also can just stop the inflammation, because this has been also been found as efficient. Now, in conclusion, we have no single treatment which is efficient, but in general, even in our settings, we combine 1, 2, or 3 treatment. In our settings, surgery, intraregional injections with triamcinolone, and cryotherapy are the most used, and they have been proving their efficiency. And I want to share our technique in aerobic keloid treatment in our setting. Our technique we have developed and which we are using and continuing to perform. As we know that the auricular is a distinct aesthetic unity to the head and neck region that demand bilateral balance and symmetry. If not, we have, just like in this patient, who is not a Muslim, but because he has bilateral keloids, just opted just to wear this kind of dressing. Now she came to us complaining with it was a bilateral keloids. Now, all the patients we have come in this situation, just they want just to be treated, and most of them we go for surgical treatment. And even for some patients, they have tried self-treatment. They use stitches, and of course, it is followed with infection, inflammation, as we see here, where this patient tried to just to tie this keloid, but inflammation was severe, and she came to us for further treatment in our settings. When we have a patient for treatment, we have to prepare the patient, of course. We have a criteria for selecting to see if the patient is predisposed to keloid formation or not. And most of them, they have bilateral, but we have seen some patients with one side keloid because of these inflammations triggered by the piercing device itself, which maintains the inflammation. Then we use the technique of the local anesthesia, tumescent local anesthesia, which is administered to the base of the keloids. This is a combination of adrenaline with normal saline. It's easier to do it in a ratio of 1 ml of adrenaline into 9 ml of normal saline. Good tumescence, and when you cut, there is no, it maintains the good hemostasis. Now, the procedure depends on the size of the regions. There are some regions where we cut and close without flap. And most of the time we use the local flap from the keloid itself, or we may use in some conditions the skin grafting from the keloid of the patients. Then the resections follow the shape of the directions of the keloid to ensure the thorough removal later on. And the wound closure, the defects are typically closed using the 5 or 9 suture, and we maintain it after we correct good correction, just orienting the ear lobe keloid to the normal shape to avoid the hematoma formation and the subsequent flat necrosis. We use this nylon stitch, which cross the ear lobe, and then this dressing is maintained for 8 days. Then after 8 days, we remove the dressing, and then the regular follow-up is done every 3 to 4 weeks with intralesional injection triamcinolone. This is where we had this our experience with the work done together with Dr. Emmanuel. And we have to emphasize on the recurrence when in post-op follow-up, because of most of them we have the follow-up which is not observed because of some patients seem to be satisfied, and then later on when they come after 1 year we have recurrences. I think we have figures with Dr. Emmanuel. Now, like in these cases, we have patient with this. It was a bilateral keloids. Now, the technique. This is just immediate post-op with where we removed the regions from here. As you see, we used the local flap, and we try to maintain the shape of the earlobe. Then we maintain it because there is a space within this wound. Then this is 5 or 6 nylon sutures. Then across this dressing from here to there, then we tight the dressing with which will be maintained for 8 days. Then this is after 8 days, you see that there is no infection. Then we remove these stitches. Now, after 3 months, the shape is like this one. Then here we consider that we follow the patient for further 2 months, but we have done 3 injections spaced from 1 or 4 weeks. This one case, we may have one small region where we use this single not leading to this technique above. Now, direct closure with 5 or 6 or 0. This is the patient. Now, the other patients, you see this child with the earlobe keloid. Now, here we removed all the keloid, but as we can't have the local flap from this area, because to avoid this, the contraction of the wound, now here we can use from the top of the keloid itself, then we use a skin graft, knowing that this will be, of course, the area of secondary
We have a few questions. So, Dr. Kagimbana, are you set to take questions?
Yeah, he's ready. You can use this machine because we can hear you, no problem.
Okay. Okay, so Josh,
yes,
are you still here?
Yes.
Hi.
Okay.
Thank you so much for the very interesting and insightful presentation. We just have a few questions from the audience, if you have a few minutes. Why are the scars after burning trauma most likely to become keloids?
Yes, the burning trauma most of the time becomes keloid because we have a strong inflammation, which in the process of wound healing. Then this is the only way to explain the even in those patients without predisposition for keloid formation in post-ban. A strong inflammation process. This is the only cause of ban the keloids in the ban
Thank
process.
you.
That's why most of the time, all bans always I use topical treatment like this potent steroids without waiting the keloid formation, or this type or this silicone gels. Even I don't wait because in pigmented skin always we have to fear this.
Okay, thank you so much. And also, if cryotherapy is not available to soften a very fibrous, hard keloid, how can it be softened before intralesional injection? Are there any other techniques?
Yes, the sequence is very important because we have to freeze the tissue, the tissue of keloids. Then it enhances the efficiency of the triamcinolone. But if we reverse the technique, there is no good process because the cryotherapy causes necrosis, one, and it softens the tissue. Then that's why the triamcinolone additionally make it efficient. Now the process is one, cryotherapy, then intralesional.
And if cryotherapy is not available, there's no alternatives to soften the keloid? That was, I think, the main question.
Of course, the combination is better. And all keloids are not done with the cryotherapy in a combination. And this I favor it when there is a large amount, there is a large size of keloids, or those targeted regions, small regions. But otherwise, intralesional, like in this area of the keloids, the area we use that when these small areas or these targeted keloid where itching is more is reported. But when we don't have a cryotherapy, then triamcinolone alone is very, very wonderful as
well. Okay, thank you. Thank you so much. And do we have time for one more question?
Yes.
Okay, great. Thank you. So we have someone asked if you would be able to elaborate a little bit more on the dilution for 5-fluorouracil and bleomycin.
The dilution of bleomycin and the fluorouracil.
Yes.
I don't have experience with the 5-fluorouracil because we don't have in our settings. And in my knowledge, the bleomycin is like 20 mil. Then we use it's 1/10 mils. Yes. Then we dilute it, and then we can conserve it when it is in a vial for like 1 month. Then you pick a small amount of you need. Yeah. With the fluorouracil, I don't have experience with it. Yes.
Okay, thank you so much. Okay, so with that, I think we can do our closing for the webinar. Thank you again so much, Dr. Uwizeyimana and Dr. Kagimbana. And thank you for answering our questions.
Thank you so much. Thank you for all attendees, to people who have attended the webinar.
So thank you very much for attending the Golden Training Committee webinar. You can follow us on all social media platforms to learn about our upcoming events and and more. Thank you very much. We'll see you again next month. Thank you very much, Dr. Kagimbana, for agreeing to present here, and Dr. Emmanuel. Thank you very much. See you all next month. Bye.